My name is Van de Keyser. I'm a neuroradiologist in Ghent University Hospital in Belgium, and welcome to this video presentation on imaging of the eye, orbits, and visual tracts. In this presentation, I got a lot of help from my friend and colleague, Dr. Stephanie van den Bossen, who works in the St. Lucas Hospital in Ghent, Belgium. So thank you very much, Stephanie, for sharing a lot of cases and former presentations with me, which was really helpful in making this presentation. And let's get started with a short introduction. What are indications for orbital imaging? Why is orbital imaging performed? There are three recurring reasons for performing imaging of the orbits and or visual tracts, and it's important to know what the exact indication is to give the patient the best possible MRI examination. One of the reasons is proptosis, bulging of the eye. Another one is visual disturbances of any nature, but it's important to specify them. If you are an ophthalmologist or a neurologist, specify the exact nature of the visual field deficits, because that will be important in deciding what is the best MRI protocol for your patient. And finally, ophthalmoplegia and or diplopia, which is suggestive for a lesion of one of the cranial nerves responsible for innervation of the extraocular muscles and thus for eye movement. And a patient with proptosis, the question is there something in the orbital compartment with space-occupying effect causing protrusion of the eye? So in these patients, we don't really care about the brain, and the patient is most benefited by a very detailed and dedicated MRI of the orbits. And a patient with the visual disturbances, it all depends on the exact nature of the visual disturbance, because this can be caused by a lesion anywhere between the eye and the visual cortex and the occipital lobes, which is a large region. So depending on the exact nature of the visual disturbance, the patient will benefit most from a dedicated MRI of the orbit, an MRI of the pituitary, or an MRI of the brain. And finally, in patients with ophthalmoplegia and or diplopia, we want a detailed evaluation of the course of the cranial nerves, the third, fourth, and sixth cranial nerve responsible for innervation of extraocular muscles. And so these patients will need an MRI of the orbit with special sequences for detailed evaluation of the cranial nerves. And we also want to examine the brainstem in these patients. So more about that later. What a little word on visual disturbances or visual field deficits. For us as radiologists, it's good to have an idea of the exact kind of visual disturbances a patient has, because that will determine the best possible MRI protocol for these patients. This is a schematic drawing of the visual system. We see the eyes, we see the optic nerve and the optic chiasm on this drawing, and our eyes detect visual information, both from the right visual field and the left visual field. And information of the left and right visual field is provided to both eyes at the same time. So the left eye gets information from the right and left visual field, and the other way around. However, something peculiar happens. You would expect that visual information of the left eye is then delivered in the left part of the brain or the right part of the brain if it crosses, and the other way around, but that does not happen. What happens is, despite the fact that both a left and a right visual field information is picked up by the retina in both eyes, all information of the left visual field finally ends up in the right occipital cortex, and the other way around. Information of the right visual field all ends up in the left occipital cortex. So part of the information that is picked up by the retina and the eyes has to cross somewhere in the brain. And where does it do that? In the optic chiasm. Let's look at information. So I already told you that information of the right visual field is received by both eyes. The inner part of the retina, located over here is called the nasal part, and the outer part of retina is called the temporal part. Let's now look what happens with information of the right visual field. So information of the right visual field is received by the nasal part of the right eye, and this information will cross in the optic chiasm to the contralateral side, while information of the right visual field picked up by the left eye does not cross but remains ipsilateral. So all information of the right visual field finally ends up in the left part of the brain and will be processed by the left occipital cortex. And the same is true, of course, for information of the left visual field. The information of the left visual field received by the left eye will cross in the optic chiasm, while information of the left visual field picked up by the right eye will not cross but remain ipsilateral. This is the optic chiasm, and the crossing happens centrally in the optic chiasm, as you will see, which will have implications for pathology of the optic chiasm, but more about that later. Now, this information crosses in the optic chiasm and is then transmitted by the so-called optic tracts to the thalamus, more specifically the lateral geniculate body of the thalamus, where they synapse, and then new axons are transmitted from the thalamus to the occipital cortex in a white matter tract called the optic radiation, or the radiatio optica in Latin, and finally end up in the occipital cortex on both sides. So we now have seen all components, anatomical components of the visual system. Information is picked up by the eye, is transmitted by the optic nerve to the optic chiasm, where part of the information crosses. So then we have the optic tract. Information is provided to the thalamus, the lateral geniculate body, and transmitted by the optic radiation to the visual cortex. This has implications for the kind of symptoms a patient might have. This is a normal situation. These are the visual fields of both eyes. Now, what happens if you have a lesion involving the eye or a lesion involving the optic nerve? Then you will have total blindness on one eye. This is called monocular blindness, and in a patient with monocular blindness, so blindness of one eye, it is important to perform dedicated MRI of the orbits, because while a total brain scan is not really necessary, we don't expect to see a lesion in the occipital cortex in these patients. The lesion must be located somewhere over here. A second situation is a lesion of the optic chiasm, and a very important one are cellular tumors, because the optic chiasm is located immediately above the sella turcica, which houses the pituitary in about 70 to 80% of cases. So a space-occupying lesion in the cellular region might compress the optic chiasm located above it. It will especially compress the central fibers, and these are the crossing fibers. So if that happens, we get the following visual field deficits. We get a so-called bitemporal hemianopia. We have visual field deficits in the outer region of both eyes, the temporal region, which can be understood taking into account the fact that information crosses centrally within the optic chiasm. And these patients, if a patient has bitemporal hemianopia, will benefit most from an MRI of the pituitary, because the most likely cause will be a space-occupying pituitary or cellular tumor compressing the optic chiasm. And finally, if a lesion occurs anywhere along the course of the optic tract, the radiatio optica, or the occipital cortex, patients will have what is called homonymous hemianopia, and they will benefit most from an MRI of the brain. This is a simplification. You also have things called quadrantanopia. Imagine you have a lesion and just a small part of the occipital cortex, then not the entire ipsilateral field will be disturbed, but only part of it, a quadrant, not the total half. But I just wanted to keep things simple. So remember, in a patient with monocular blindness, you should request an MRI of the orbits. In a patient with bitemporal hemianomia, MRI pituitary is most applicable. And in patients with homonymous hemianopia or quadrantanopia, do an MRI of the brain. This presentation will mostly be about MRI of the orbits, because despite the fact that the orbit, the small pyramid-shaped bony structure containing the globe of the eye and the other components of the eye, despite the fact that it's very small, it's very rich in anatomy, and there is a wide variety of pathology that can be encountered there. So as said, the orbits are basically pyramid-shaped or triangular-shaped bony structures housing the eye, providing protection to the eye. And where does the orbit really start? Well, there's a very small fibrous structure, a septum, which basically provides the anatomical border of the orbital compartment called the orbital septum. I'm going to show you where it is located exactly, but about over here, as indicated by the lines on this drawing. Then in the orbit, we find the extra-ocular muscles, and the combination of the extra-ocular muscles and the fascia enveloping them is called the conal space. And then we have fatty tissue containing arterial and neural structures located on the in and outside of the conal space. When it's located on the outside, we call that the extraconal space, and on the inside, the intraconal space. And this division of the orbit and several anatomical compartments is very helpful when trying to provide a differential diagnosis of pathology. So that's why in this presentation, I'm going to use this compartmental approach. I'm going to start by showing you bony orbital anatomy and pathology, followed by anatomy and pathology of the globe. And then we're going to talk about the conal space, intraconal space, and extraconal space. And finally, we're also going to discuss lesions located outside of the orbit, which might cause visual field deficits or cranial nerve palsies. We're going to talk then about extraorbital pathology of the visual system. This is going to be a long presentation, so I'm probably going to record it in several parts, and this is part 1, anatomy and pathology of the bony orbit. Let's start with some anatomy. The bony orbit is composed of 7 bones: the frontal bone, sphenoid bone, zygomatic bone, maxillary bone, the lacrimal bone, ethmoid bone, and a very small part of the palatine bone. I'm going to show these bones on images in a minute. The bony orbit has 4 walls. We have an orbital roof, there's an orbital floor, we have a lateral orbital wall, and a very thin medial orbital wall. What do these look like on images? Let's start with the orbital roof. The orbital roof has 2 major components, and I'm showing you sagittal images because the 2 are best seen on sagittal images. For the most part, the orbital roof is composed of the orbital plate of the frontal bone, and then at the back, overlying the optic canal, we have a small part of the lesser ring of the sphenoid bone, and this structure over here is the anterior clinoid process of the sphenoid bone. In the orbital roof, we can sometimes see these very small holes. These can have a small opening to the orbit, and in that case, they're called supraorbital notches. And sometimes the opening is missing, and they are completely located within the bone of the frontal bone. In that case, we call them not a supraorbital notch, but a supraorbital foramen. And these contain the supraorbital nerve. This is one of the branches of the ophthalmic division of the trigeminal nerve, and this nerve is responsible for the sensory innervation of the upper eyelids and the forehead region. Then let's move on to the orbital floor. The orbital floor is for the most part composed of the orbital plate of the maxillary bone. There's also a small component of the zygomatic bone and a very small component of the palatine bone at the back, which is not visible on these images. If I remove this, then take another look at this structure over here. What is this small hole? This is also a foramen. This is the infraorbital, well, not a foramen, but a canal, the infraorbital canal, which contains the infraorbital nerve. The infraorbital nerve is a branch of the maxillary division of the trigeminal nerve and provides sensory information for the lower eyelid and the skin located superficially of the maxilla and that region. Then we have the medial wall, which also has several components. We have the frontal process of the maxillary bone, not visible on these images. We have located anteriorly, often quite thick, and despite the fact that it's not visible on these images, also containing a small opening for the lacrimal sac and canal. We have the lacrimal bone. Then we have the very thin ethmoid bone, also called the lamina papyracea, the paper thin lamina, because it is so thin. And then we have the sphenoid bone at the back. Then finally, the lateral wall has two important components. We have the zygomatic bone and we have the greater wing of the sphenoid bone. Understanding bony anatomy is important to understand pathology, of course, and as a radiologist, you can never know too much anatomy. There are three important openings in the bony orbit, which are necessary for transmitting various nerves, arteries, and veins. We have the optic canal, we have the superior orbital fissure, and we have the inferior orbital fissure. In the optic canal is an opening for the optic nerve and the ophthalmic artery. And the superior orbital fissure, this is an opening for the oculomotor nerves, the third, fourth, and sixth cranial nerve, but it also transmits several branches of the trigeminal nerve and the superior ophthalmic vein. The inferior orbital fissure, lastly, also transmits several cranial nerves, branches of the maxillary division of the trigeminal nerve, and also the inferior ophthalmic vein. I think the most important thing to remember is that the optic canal transmits the optic nerve and the superior orbital fissure is an opening for the oculomotor nerves. I think that's the most important thing you need to remember concerning these openings. And you can also see them on imaging. This is a three-dimensional reconstruction of a CT of the brain, and this is the superior orbital fissure, and here we have the inferior orbital fissure located between the maxillary bone and the sphenoid bone. We can also see them on axial images. Over here we have the optic canal for the optic nerve with the anterior clinoid process located laterally of it. And this opening over here is the superior orbital fissure. Let's talk about some pathological conditions. I made a distinction between two groups of pathologies, bony tumors and orbital fractures. Let's talk about bony tumors to get started, and this is a must-know diagnosis for any radiologist, I believe. This patient presented with a chronic proptosis, slowly progressive. This is a line drawn between the most anterior aspect of the zygomatic bones. We call this the interzygomatic line, and we see that the right eye is located almost completely in front of the interzygomatic line. That's not okay. This is a proptosis, and I'm going to show you how to classify proptosis on images in a minute. And if we then look at the bony kernel, we find a reason. If a patient has a proptosis, that means there has to be something extra located in the orbital compartment. In this case, it's an expansile and even aggressive looking bony lesion. In my experience, the first time a radiologist sees this kind of thing and has for the rest little background in neuroradiology, the first thing we worry about is this is an aggressive bony tumor. Well, it isn't, and it's in what we call Antomy diagnosis. If you've seen it once, you'll recognize it immediately the next time, and it's practically always a very similar imaging appearance. Let's magnify this a bit. Here we see an expansile hyperostotic lesion, somewhat irregular bony margins. You could even wonder if this is periostal reaction, which in the world of bony radiology is a sign of a very malignant or high-grade process, but in this case it isn't, and it's also not true periostal reaction in this case. We also see that this process causes a reduced volume of the orbital compartment and compression and deviation of one of the extraocular muscles, and this is going to be very likely the lateral rectus muscle. If we look at the MRI images of this patient and we magnify it a bit, we see two things. We see here the hyperostotic bone of the sphenoid wing. This is the greater sphenoid wing. And we see here a contrast-enhancing lesion located extra-axially. This was what we call en plaque, so a plate-like or plate-shaped meningioma located along the back of the greater sphenoid wing. And why this is the case, I do not really know, but these are often associated with a very aggressive appearing hyperostotic reaction of the overlying bone of the greater sphenoid wing, causing a proptosis. So Antomy diagnosis, if you've seen it once, you have seen them all. So the patient had a proptosis. Is it possible to give an estimate on the severity of the proptosis on images? Well, yes, there is. In a normal situation, the posterior margin, this is the interzygomatic line, so the reference line we're going to use, and in a normal situation, the posterior margin of the sclera should be located more than 6 millimeters behind the interzygomatic line. If the posterior margin of the sclera is located less than 6 millimeters behind the interzygomatic line, we're talking about a grade 1 proptosis on imaging. If the posterior margin is located at the interzygomatic line, this is a grade 2 proptosis, and a grade 3 is when the eyeball is located completely in front of the interzygomatic line. So this is just a way to give some kind of radiological estimate on the severity of the proptosis. Let's return to bony pathology. Something is off. This patient also has proptosis of the right eye, as you can see, and something is missing. Do you see what it is? Well, let's compare with the other side. What is this? This is the greater wing of the sphenoid bone, and it is completely absent on the other side. This is a sphenoid wing dysplasia, or in this case, even aplasia. This is not something you will see frequently, but if you see it, it will be almost always in one specific pathological condition, namely neurofibromatosis type 1. Neurofibromatosis type 1 is a genetic condition characterized by the presence of, for instance, neurofibromas, very small benign tumors of peripheral nerves, and that's why they call it neurofibromatosis, of course. But in 5 to 10% of these patients, the sphenoid wing, generally unilaterally, will be dysplastic or even missing. This is sphenoid wing dysplasia, and why this occurs in these patients is actually a bit unclear. It's just something that occurs in these patients, and it's also one of the diagnostic criteria for neurofibromatosis type 1. This is the same patient, and we see that due to the absence of the greater sphenoid wing, there is complete protrusion of temporal lobe tissue towards the orbital compartment, causing a proptosis of the right eye. And on these three-dimensional reconstructions, we see that the sphenoid wing, which can be seen over here and the ipsilateral normal side, is completely missing in this patient. So I already said this, is seen in 5 to 10% of patients with neurofibromatosis type 1 and is one of the diagnostic criteria. Now, these two are, I believe, very important for you to know, but of course you can encounter a variety of bony lesions in the orbital roof, and I'm just going to show you a few of them, cases I've seen personally. Here we have an expansile lesion with a lytic center located in the right orbital roof. There is no real cortical breakthrough. The cortex looks a bit thinned at several spaces, no periostal reaction, and very characteristic, we see thickened trabecula located within this bony tumor. And the presence of thickened trabecula is very characteristic for one specific entity, namely a bony hemangioma, which is a benign vascular lesion which causes lysis of soft bone but compensatory thickening of thick trabecules or trabecula, leading to trabecular thickening centrally within the lesion. Bony hemangiomas look the same in any kind of bone, so the appearance of an orbital hemangioma, orbital bone hemangioma, is not different from what they look like in other parts of the body. The same is true for this lesion. We see a very expansile lesion causing a reduced volume of the right orbital compartment. The lesion is located in the left orbital compartment, is located in the left orbital roof. It is surrounded by cortex. There is no cortical breakthrough, no periostal reaction, and the lesion also has, at several places, a ground glass matrix. And this is very characteristic for fibrous dysplasia. Once again, fibrous dysplasia looks like this no matter where you encounter it, in this case, in the orbital roof. Final example, we see a bony lesion with a central fluid-like hypodense content, some calcifications. The orbital roof looks as if it's missing, it looks eroded, and there is compression of the eyeball by the lesion. This was a patient with a slowly progressive chronic proptosis, and on bony coronal images, we see that there is bony erosion, but it looks still rather benign. There is scalloping of the bone over here, so this looks like slowly progressive chronic pressure erosion of the bone. And on the soft tissue kernel, the lesion seems to have a fluid-like hypodense content. On T2-weighted images of the brain, the lesion is hyperintense, but it contains irregularities as heterogeneous, and this is the most important sequence. The lesion has a high signal on the fusion-weighted images and a low signal on the ADC map. This is the fusion restriction, and this is seen in one specific bony lesion, or kind of bony lesion, namely a bony epidermoid cyst. Epidermoid cysts or congenital cysts. They are cysts aligned by epithelium, and these epithelial cells chronically secrete keratin, and keratin debris is very viscous and causes diffusion restriction. So diffusion restriction is very characteristic for epidermoid cysts, no matter where you find them, because they do not only occur in the bone, quite the contrary. So let's summarize. When it comes to bony lesions of the orbit, I think a radiologist should definitely be able to immediately recognize an en-plaque sphenoid wing meningioma for what it is, based on the presence of hyperostosis in the sphenoid wing. This is an Antomy, and I always tell my residents, if I show this to you on your final examination, for me, it's a deal breaker. It's an Antomy. You should immediately be able to say, this is going to be en-plaque sphenoid wing meningioma. Remember that if a patient has aplasia or dysplasia of the sphenoid wing, the patient will very likely have neurofibromatosis type 1, and it's a diagnostic criterion for neurofibromatosis type 1. And lastly, if you see any kind of bony lesions, the differential diagnosis is basically the same as it would be for bony lesions in other parts of the skeletal system. So if you have no idea, then maybe consult your local musculoskeletal specialist. Maybe he will help you with the diagnosis. Let's now talk about orbital fractures. There are two important kinds of fractures in the orbital region you should know. This is the first one. We see this patient has a fracture of the left inferior orbital rim, and we see some herniation of intraorbital fat into the left maxillary sinus. We also see that the fracture is located at the level of the infraorbital canal and orbital floor fractures are often located or go through the infraorbital canal. Nevertheless, patients can have transient sensory deficits in the territory of the infraorbital nerve, but these are generally transient. I'm not saying there are no exceptions, but in most cases, this does not lead to permanent sensory deficits or disturbances. Then this is important. If you have a patient with an orbital floor fracture, it's important to look up the location of the inferior rectus muscle, which is located immediately above the orbital floor, and also evaluate the shape of the inferior rectus muscle. These fractures, orbital floor fractures, are also called blowout fractures and are generally the result of a straight impact on the orbit. Why is it important to evaluate the location and the size of the inferior rectus muscle? Well, let's take a look at another example. We see a patient with a blowout orbital floor fracture. We see there's a displaced bony fragment in the maxillary sinus, and there is also complete opacification, hyperdense of the left maxillary sinus, so this is blood. We see that there is herniation of intraorbital fat into the displaced fracture, but we also see that there is something peculiar with the inferior rectus muscle. This is a normal inferior rectus muscle on the contralateral side, and we see that on this side it has migrated partially within the defect caused by the fracture. This is an important thing to look for, and this is an important thing to tell your physician, because if the situation is not corrected, it can lead to necrosis of the inferior rectus muscle and permanent diplopia. So this can be a reason to perform surgery in these patients. In some cases, you will immediately see there's a herniation of the muscles, like in this case. In this patient, we see over here a fracture of the right orbital floor. And if we look at the inferior rectus muscle, let's first look at the normal right one, plate-like. We see that on the other side, it is slightly located more inferiorly, but also has a round shape. And this change and contour deformity is also suggestive for some displacement. Because the fracture fragment is somewhat depressed, the muscle gets slightly pulled along with it, causing a contour deformity. So this is not a full-blown herniation, but nevertheless it is suggestive for limited herniation of the rectus muscle and should be communicated with your referring physician. Then another type of fracture, this looks like a complex fracture. And if you're dealing with complex maxillofacial fractures, it's important for yourself to keep it simple by trying to look for a specific fracture type. And in this case, well, let's first look at what components of the maxillofacial structures are involved. This patient has a fracture of the anterior maxillary sinus wall and the posterolateral maxillary sinus wall, so the maxillary sinus is involved. And then we have a fracture of the zygomatic arch, also of the lateral orbital wall, which is composed of zygomatic bone and the greater ring of the sphenoid process, as you know. Here we see also the fracture of the lateral orbital wall, but also of the orbital floor. This combination of fractures or constitute a zygomato-maxillary complex fracture. So basically we have fractures of the maxillary sinus and also of the various components of the zygomatic bone and various zygomatic sutures in these patients. And if we look at the three-dimensional reconstructions of this same patient, we see fractures centered along the zygomatico-frontal suture, along the zygomatico-temporal suture, and the zygomatico-maxillary suture. If these three sutures are involved, it's sometimes also referred to as a tripod fracture. And if there is also involvement of the zygomatico-sphenoid suture, which is not visible on these images, we can call it a tetrapod fracture instead of a tripod fracture. So let's summarize. orbital fractures, we have two important types. We have the blowout orbital floor fracture. This is wrong, orbital floor fracture, which is a fracture of the inferior orbital rim, often with involvement of the infraorbital canal, and it's very important to evaluate the location and the morphology of the inferior rectus muscle. We have to rule out inferior rectus muscle herniation to avoid our patient developing a permanent diplopia. Then we have another fracture type, the zygomatico-maxillary complex fracture, which is basically a fracture involving the components of the maxillary sinus, more specifically the anterior and the posterior maxillary sinus wall and the inferior orbital rim or the orbital floor. And these patients also have fractures of the lateral orbital wall and the zygomatic arch. And these patients, often surgery is performed because due to displacement, this leads to a cosmetic deformity of the face, which is not difficult to imagine. If you look at this fracture, look especially over here at the where the zygomatic bone and the maxillary sinus meet. This looks displaced, and this will be visible aesthetically, and it can also lead to dental malocclusion, which is also a reason to correct these fractures surgically. Okay, that concludes the first part of this presentation on orbital anatomy and pathology. The next topic will be about anatomy and pathology of the orbital globe, or of the eyeball. Hello, and welcome to this second presentation on anatomy and pathology of the eye, orbits, and visual system. And in this presentation, we're going to talk very specifically on anatomy and pathology of the eyeball or the globe. Let's start with some anatomy. So the globe constitutes about 1/3 of the orbital content. So it's a very important structure. Also, of course, it's an important structure from an anatomical and a functional point of view. And it has various components. Over here, we see the lens, responsible for breaking the light entering into the eyeball, and the lens can be used as some kind of anatomical reference point. Located posteriorly of the lens, between the lens and the retina, we find the posterior segment of the eyeball, which contains the vitreous body, and the vitreous body is composed of a clear watery gel. Then anteriorly of the eye lens, between the cornea and the eye lens, we find the anterior segment of the eyeball, which is filled with watery fluid. So not gel-like fluid like in the vitreous body, but watery fluid. So these are the two segments of the eyeball, and we have the eye lens as a reference point dividing the two. Then the globe is enveloped by a wall, and this wall is composed of 3 layers. And the most important one from a functional point of view is, of course, the most inner layer, the retina. And the retina contains the photoreceptors, so it's basically responsible for transmitting light into electrical signals, which are passed along through the axons to the optic nerve. Two terms I'm going to introduce here. We have the ora serrata, which is the peripheral end of the retina. So the retina does not go all the way to the front of the eyeball, so it ends about halfway, maybe a little bit higher than I've drawn here, but it doesn't really matter. So remember that term, ora serrata. And then we have the optic disc, or the optic papil, or the optic nerve head, which is basically the point where axons in the wall of the eye, where axons leave the eye and enter the optic nerve. Let's talk a bit more about the layers of the eye wall or the globe wall. So there are basically 3 layers. To keep it simple, we have an outer layer, which is a fibrous layer. We have a middle layer, which is a very vascular layer. And then we have the inner layer, which is the neuronal layer containing the photoreceptors of the eye. This is, of course, the retina. When talking about the outer layer or the fibrous layer, there are two parts. There is the sclera, which is located along most of the eyeball and is opaque. But we also have an anterior part located in front of the iris and the eye lens, and this is called the cornea, and the cornea is transparent. When it comes to the middle layer, also called the uvea, this is a vascular layer, contains a lot of blood vessels, and there are three important structures. We have the iris. The iris is located in front of the eye lens, and it contains a central opening. And the iris contains very small muscles, and these can contract or they can relax. And this contraction or relaxation of these internal small muscular structures will cause the pupil of the eye to narrow or dilate. Then we have the ciliary body located over here, and the ciliary body contains very small muscles which are connected through fibers called the fibers of Zinn, as you can see here, to the eye lens. And these muscles in the ciliary body are responsible for the accommodation of the eye lens. And finally, we have the choroid layer, which is located along most of the eyeball and contains, as said, a lot of blood vessels. And then finally, we have the inner layer of the eyeball, the retina, which is composed of the inner sensory retina containing the photoreceptor cells and an outer retinal pigment epithelium. Dan, can we see those layers on imaging? Kinda, but not all of them. This is a 3 Tesla examination, and let's magnify this a bit. Here is the optic nerve by way of a reference, and then we see two layers on these T1 weighted images. On T2 you will not be able to see them. We have an inner T1 hyperintense layer, and this is the choroid. And why is it T1 hyperintense? Because this very vascular layer also contains melanocytes, and melanin is hyperintense on T1 weighted images, as you know. Then we have an outer hypointense layer, which corresponds to the fibrous sclera, and the retina cannot be delineated on your standard 1.5 or 3 Tesla MRI examination. So we just have to assume it's there on top of the choroid. On T1 weighted images without gadolinium, the choroid is T1 hyperintense, and if you give gadolinium, because it's a very vascular layer, it will enhance. And we see a nice enhancement of the choroid layer along the eyeball. And the most anterior component over here, this corresponds to the ciliary bodies, and we can't really see the fibers of Zinn, but they are there. There are very small fibers of Zinn connecting the ciliary bodies to the eye lens. On T2 weighted images, we can also see the iris. Look very carefully, and here are some colors. This is the iris, responsible for controlling the size of the pupil. I'm going to remove the text and the colors now, so look again. There's the iris located on top of the eye lens. And we also see very faintly these very discrete, somewhat subtle linear structures, which correspond to the fibers of Zinn that connect the ciliary bodies to the eye lens. And these two structures divide the anterior segment of the eye in two parts. As said, the anterior segment is filled with a watery fluid, and we have an anterior chamber, which is the watery filled space between the cornea, the transparent layer of the sclera, of the outer layer rather, and the iris, so the anterior chamber between the cornea and the iris, and a posterior chamber, very small, between the fibers of Zinn and the iris. This is wrong. This should be the iris, not the retina. So these constitute the anterior segment, and the posterior segment, as said, is filled with the vitreous body, which is a gel-like substance. Then I'm going to show you now several frequent incidental findings involving the eyeball on imaging studies that you should not mistake for pathology. I'm going to show you calcified drusen, scleral calcifications, trochlear apparatus calcifications, and some situations after eyeball surgery. Let's start with scleral calcifications. If you look at the upper image on the left, you see these very small calcifications located along the eyeball. Okay, and these correspond to senile calcifications at the insertion of the medial and lateral rectus muscles. They are a very frequent finding on CT studies, especially in elderly patients. And the patient on the left side, at the bottom, we see very small calcifications located at the level of the optic disc, and these are calcified drusen. They are foci of mineralized hyaline degeneration of the optic disc, very often an incidental finding in a patient who is asymptomatic. Well, that is to say, these are incidental findings and not a cause of symptomatology. And then we have trochlear apparatus calcification, strictly speaking, not a lesion of the eyeball, but I'm going to discuss them here because it makes sense when talking about incidental findings. And you see these very small calcifications located supromedially in the intraorbital compartment. And what are these? These are calcifications of the trochlear apparatus. And the trochlear apparatus is basically a small cartilage ring through which the superior oblique muscle passes. So the superior oblique muscle is one of the extra-ocular muscles, and it makes a 90-degree turn, forms kind of a sling, because it runs first parallel with the medial orbital wall and then makes a 90-degree turn to end up on top of the eyeball. So to make that turn, it needs some kind of sling, and this is a small ring through which this muscle passes, and this can also calcify as patients get older, so don't mistake it for pathology. Then let's talk about another frequent finding, pseudophakia or intraocular lens implants after cataract surgery. This is an MRI image, and while a normal lens is hypointense and biconvex, on T2-weighted images, here we see these small plate-like structures, which are intraocular lens implants. This is a patient in whom the left eye was removed for whatever reason. This is an enucleation of the left eye. And sometimes these patients receive an eye prosthesis. And this eye prosthesis can have several components. A model that is often used is one consisting of an upper prosthesis and an orbital implant. And this is on an axial image. We can also see that on a sagittal image. Here is the prosthesis, and here is the orbital implant. And this is a three-dimensional reconstruction showing you the eye prosthesis. Very often, the extraocular muscles are placed or inserted upon the orbital implant, as you can see on these images over here, but the optic nerve, of course not, is no longer functional and detached. Then, are these scleral calcifications? At first you'd say yes, but if you look at a few images higher and lower, you see a small band-like rim of density enveloping the entire eyeball. So not just located at the insertion of the medial and lateral rectus muscles. So it was not possible for me to make a reconstruction showing you how it goes around the eyeball completely. This is a coronal image, but you can imagine it does. Okay, so what is this? This is a so-called scleral band. And a scleral band is a technique used in ophthalmology to correct a retinal detachment. What they do is they insert a band around the eyeball, which basically presses the retina against the rest of the eyeball, closing a small tear in the retina, which gave rise to retinal detachment. And another technique that can be used is the intravitreous injection of silicone, as you see here. We see an eyeball with a very dense content, If you don't know any better, you'd say, well, this might be blood, but it's generally even more dense than blood. And this was an intravitreal silicone injection. So before calling this an intraocular hemorrhage, maybe consult your ophthalmologist if maybe this patient didn't receive an intravitreal silicone injection because of retinal detachment. Now, I'm going to talk about the following pathological conditions: abnormalities of the globe shape, detachment of the retina and choroid layers, intraocular tumors, and, well, this is going to be for another time. I'm not going to talk about eye trauma. This is a patient with a coloboma. We see that there is a focal extrusion and widening of the posterior eyeball at the level of the optic disc. This is a congenital lesion, but is often confused with the so-called staphyloma. And a coloboma, which is a congenital defect, which can basically be located anywhere along the eyeball, but is often located posteriorly at the level of the optic disc. And a congenital coloboma, we see a focal protrusion of the eyeball posteriorly nicely at the level of the optic disc, while in a staphyloma, and this patient not only has a staphyloma but also an intraocular lens implant over here, but that's not that important now. In a staphyloma, we see basically an abnormal eye shape, mostly of the posterior component of the eyeball, but it's not exactly located at the level of the optic disc and often more temporal of the optic disc, as you can see here. What is a staphyloma? A staphyloma is basically a weakening, a chronic weakening of the layers of the globe, of the eyeball wall, and is often seen in patients with chronic or long-standing myopia. So if it's very focal and located at the level of the optic disc, especially in younger patients, it's going to be a coloboma, a congenital global wall abnormality. In older patients, if it's more diffuse and more temporal of the optic disc, it's a so-called staphyloma, acquired condition often associated with chronic myopia. And here are some other examples, and you see this quite frequently, especially in the older population. Several patients with myopia or with staphylomas rather, and some of them also with intraocular lens implants, which is also a very frequent incidental finding. If the lens is completely absent, we call that an aphakia, but I have no examples of that to show you in this presentation. Let's talk about detachment. We are going to talk about retinal detachment and detachment of the choroid layer. And what is a retinal detachment? Well, the word says it's basically the retina becoming detached of the underlying choroid layer, and the space between the retina and the choroid is filled with fluid. And a retinal detachment typically has a V shape, which has to do with the anatomy of the retina. As said, the retina does not run all the way to the front of the globe, but ends at the level of the ora serrata, which is located roughly over here, and then runs towards the optic disc, which is roughly located here, hence the V shape of the retinal detachment. On FLAIR images, we see that the contents are FLAIR hyperintense, which is suggestive for more proteinaceous fluid. So what is a retinal detachment? Basically the accumulation of fluid underneath the retina, between the retina and the choroid, or between the two retinal layers. And it can have various causes, but the most frequent cause is basically some kind of degenerative tear. These we call the rhegmatogenous type of retinal detachment. And fluid then leaks from the vitreous body underneath the retinal layers. And finally, it is V-shaped, as said, because the retina stays fixed at the level of the ora serrata over here and at the level of the optic disc over here. The following kind of detachment is a choroid detachment, and the distinction with a retinal detachment is quite easy because it looks totally different. In a choroid detachment, we often have some kind of more convex detachment, and the choroid is more strongly fixated, not at the level of the optic disc, but slightly laterally of it. So this can extend all the way to the level of the ciliary bodies, of course, but it does not extend to the optic disc, but stays a bit laterally of the optic disc. And it often gives these kind of biconvex protrusions or fluid-filled structures within the eyeball. This is the two-weighted image. This is the one-weighted image, so the content is slightly less hypointense than of the vitreous body. We see nice enhancement of the choroidal layer on these T1 weighted images with gadolinium and also on these coronal T1 weighted images with gadolinium. The exact cause of this choroid detachment is a bit unclear to me, but we see that there is more going on in this patient, as the patient also has contrast enhancing infiltration in the superior extraconal space over here. But I cannot remember what was exactly going on in this patient. Now, choroid detachment is the accumulation of fluid between the choroid and the sclera. It is often or most commonly seen after glaucoma surgery, but can also be seen in trauma and infection. In trauma, it will be filled with fluid, with blood rather, and in infections often with transudates or exudates. And in a choroid detachment, there is diversion away from the optic disc, so it does not converge all the way to the optic disc, but it also extends beyond the ora serrata, making the distinction with retinal detachment actually quite easy. This is a patient with a traumatic choroid detachment, and we see that there's a fluid-filled space underneath the choroid filled with dense hematoma. This is another patient with a retinal detachment, nicely seen on T2 weighted images. The contents are high of signal on flare, indicating proteinaceous fluid. And on T1, we see no hemorrhage, not hyperintense on T1. But then on T1 with gadolinium, we suddenly see a contrast-enhancing plate-like lesion in the eyeball. This was a patient with breast carcinoma. And if you see a retinal detachment in a patient, especially in older patients, especially in patients with a history of malignancy, definitely do contrast-enhanced sequences, because a cause for retinal or choroid detachment can be an underlying ocular neoplasm, as was the case in this patient. This patient thus had a so-called uveal metastases, and this is not that infrequent. It is the most common intraocular tumor, and the most common primaries are breast and lung carcinoma, followed by melanoma. The lesions are contrast enhancing and often plate-like, not nodular, and they can cause retinal or choroidal detachment. This is another patient with an intraocular tumor. Once again, we have a retinal detachment, and then we have this now nodular lesion, which is somewhat hypointense on T2 weighted images, located in the right eye. And on T1 weighted images, mind you, this is not contrast enhanced. This is unenhanced T1 weighted sequence. We see that the lesion is hyperintense. Now, this is very interesting because that makes the lesion very suspicious for uveal melanoma. Uveal melanoma is the most common primary intraocular malignancy in adult patients, typically in age ranges 50 to 70, but of course that's not absolute. And it involves the choroid more than it does the ciliary body or the iris, but of course involvement of the ciliary body and iris are possible. And what is very characteristic for them on imaging is that they can be T1 hyperintense, provided we are dealing with a melanocytic melanoma. Keep in mind that some melanomas are amelanocytic, and these will not be T1 hyperintense. This is a 3-year-old female girl. Of course, she's a female girl. This is a 3-year-old girl, rather, with leukocoria, meaning that the eye looks white. If you look at it, I'm going to show you an image. So the pupil looks white when reflected by light. And this is because there is something in front of the retina. And in this patient, it is a tumor. We see once again a retinal detachment, and this time we see a very large intraocular lesion, somewhat hypointense on T2, and on T1 weighted images not hyperintense. So it's black on T1 weighted images. And here are the T2 and T1 weighted images again. If we now look at the T1 weighted images with gadolinium, we see some very faint enhancement, not in your face, but it is there. And these are the coronal T1 weighted images. The process reaches all the way to the islands. And there is detachment seen posteriorly of the tumor. These are the CT images in this patient. So we try not to do CT images of the eyes because we do not want to irradiate the eyes, but sometimes we have to. Don't know why it was performed here, but it was performed, and we see that the tumor contains a lot of very small speckly calcifications. And this is very suggestive for one particular tumor, namely retinoblastoma. Retinoblastoma is the most common intraocular tumor in children. It is a very malignant tumor arising from retinal neuroectodermal cells. And clinical, these patients have a leukocoria. They have a white mass between the pupil, and this is also referred to as cat's eye. So it is the most common primary intraocular tumor in children, especially in very young children. Retinoblastomas can be sporadic or genetic, in which case they are associated with mutations in the retinoblastoma 1 gene. And if they are genetic, they can be bilateral or in some cases trilateral. Of course, you do not have 3 eyes. In a trilateral retinoblastoma, there is also a tumor in the pineal gland. On CT, these tend to be heterogeneous tumor, and very characteristic is the presence of calcifications on CT, which is seen in 90% of patients. So let's summarize our intraocular tumors. We have seen 3 types. We have seen uveal metastases, which are the most common intraocular tumor in adults. We have seen uveal melanoma, which is the most common primary intraocular tumor in adults, and we have seen retinoblastoma, which is the most common intraocular tumor in children. And keep in mind when it comes to imaging that uveal melanomas, if they are melanocytic, will be hyperintense on T1 weighted images, and retinoblastomas contain calcifications in 90% or more than 90% of cases. Also keep in mind that if you see a retinal or a choroid detachment, especially in older patients, especially if there's a history of malignancy, do contrast enhanced images to rule out an underlying tumor. And this concludes my presentation on anatomy and pathology of the eyeball. The next part of this presentation will be about the conal space, so the extraocular muscles. Welcome to this third video on imaging of the eye, orbits, and visual tracts. In this video, I'm going to talk about the conal space, and the conal space is basically boils down to the extraocular muscles. So we're going to talk about anatomy and pathology of the extraocular muscles. Now, this is the eye, self-evidently. This here is the medial side of the eye. This is the lateral side of the eye. And we have a total of 6 extraocular muscles responsible for eye movement. We have the superior rectus muscle on top of the eyeball, the inferior rectus muscle underneath the eyeball, the medial rectus muscle and the lateral rectus muscle, so that's quite easy to remember, I believe. Then we have 2 oblique muscles, so muscles that do not run straight, but make a curve or a turn, like the inferior oblique muscle underneath the eyeball and the superior oblique muscle on top and on the medial side of the eyeball. Now, the superior oblique muscle makes a 90-degree turn, and this turn is made in a small ring of cartilage tissue called the trochlear apparatus. A final muscle not responsible for eye movement, but for the elevation of the upper eyelid, is the levator palpebrae muscle, which is located on top of the superior rectus muscle. Here are the muscles illustrated on a coronal T2 weighted image of the orbit. Here we have the superior rectus muscle, inferior rectus muscle, the medial and the lateral rectus muscles. The inferior oblique muscle is very, very hard to see on standard images and is not visible on the image I provided here. Then we have the superior oblique muscle, which is located superlaterally in the orbital space, and as said, makes a 90-degree turn in the trochlear apparatus. And finally, we have the levator palpebrae muscle on top of the superior rectus muscle. The extra-ocular muscles can also be seen on axial images, of course, and here we have the medial and the lateral. Oh, this is wrong. We have this is a mistake. We just see the medial and the lateral rectus muscle on this image, and we see that they insert on the sclera of the globe. Oh, I know what I mean. What I mean is that the several rectus muscles and the superior oblique muscle all insert on the sclera of the globe. And here we just see the medial and the lateral rectus muscle, of course. And what's more, they also have a common origin, namely the annulus of Zinn, located at the orbital apex. And what is the annulus of Zinn? The annulus of Zinn is basically a small ring of a fibrous tissue located deep within the orbit at the level of the orbital apex and surrounding part of the superior orbital fissure, the inferior part, and also the optic canal. It's also called the common tendinous ring because basically all extraocular muscles, with the exception of the inferior oblique muscle, insert here or originate here. And it's also called the annulus or the ring of Zinn. And we can suspect it on this three-dimensional reconstruction of the orbit located over here. Here we see the superior orbital fissure, and it involves the inferior part of the superior orbital fissure and the optic canal. Now, there are several important neuronal structures which are located at the level of the annulus of Zinn, namely the optic nerve, which runs through the optic canal. We have the oculomotor nerve, which has two branches intraorbitally, a superior branch, which innervates the superior rectus muscle, and an inferior branch innervating the I can't find it. The other extraocular muscles, well, not all of them, but the medial, the inferior rectus muscle, as well as the inferior oblique muscle. And finally, we have here the abducens nerve innervating the lateral rectus muscle. So it's a ring of fibrous tissue, origin of the rectus muscles and the superior oblique muscle, and surrounding the optic canal and the inferior part of the superior orbital fissure. And that concludes this short introduction on anatomy. Let's talk about pathology. And when it comes to pathology of the extraocular muscles, there are three important entities you should know, namely thyroid eye disease, also called Graves' orbitopathy, orbital pseudotumor, or also called, and that's probably a more correct term, idiopathic orbital inflammation, and finally, lymphoma of the extraocular muscles and other tumors, but I'm just going to talk about lymphoma here because it's the most frequent. Now, this is a patient with a chronic, slowly progressive painless proptosis. And what do we see? Both on these axial and coronal CT images of the orbits, we see diffuse enlargement of basically all visible extraocular muscles. Here is a line indicating the interzygomatic line, and we see that this is a severe grade 3 proptosis with the eyeball extending in front of the interzygomatic line. And the first thing you should think about when you see this, also taking into account the paleness and chronic aspect of the development of the symptoms, is thyroid eye disease, because it is the most frequent cause of proptosis in adult patients. And the proptosis is caused by enlargement of the extraocular muscles, but also by an increase in the volume of orbital fat, which leads to a decreased orbital volume and proptosis. Thyroid eye disease is mostly bilateral in about 90% of cases and mostly symmetrical in about 70% of cases, which is also important in the differential diagnosis with idiopathic orbital inflammation, but more about that later. This is Marty Feldman, a famous comedic actor who played Igor in Mel Brooks' The Young Frankenstein. And well, he is well known for his let's say, facial appearance. He has these very large bulging eyes, and this is because Marty Feldman suffered from thyroid eye disease. And he made this his strong point because his facial features were an important part of his appearance. And well, it's hard to say that he made his strength, but well, that's what he did. He made it one of his strengths as a comedic actor. Well, thyroid eye disease is associated with autoimmune hyperthyroidism, especially Graves' hyperthyroidism. And the development of thyroid eye disease has nothing to do with the thyroid function. So you can see it in patients who are hyperthyroid, but also after normalization of the thyroid function, patients can have the clinical manifestations of thyroid eye disease. And why is that? Because the disease is not caused by the increased levels of thyroid hormones. No, it is caused by the antibodies that are formed in this autoimmune disease, more specifically the presence of anti-thyrotropin receptor antibodies. And these probably, this is a theory, probably activate thyrotropin receptors in orbital cells, the orbital fibroblasts, and these cause these fibroblasts to change into adipocytes, so fatty cells, leading to an increase in the volume of orbital fat. And furthermore, these fibroblasts produce collagen and hyaluron. Oh my God, I can't pronounce it in English, so I'm going to do it in Dutch, hyaluron, in extraocular muscles and fat, leading to edema in the extraocular muscles and fat and the development of muscle enlargement, orbital fat increase, and proptosis. This is another patient with thyroid eye disease. We see axial and coronal CT images, and we see diffuse enlargement of basically all extraocular muscles. And two things are also very apparent on this image. On the axial image, we see that it are mainly the extraocular muscle bellies that are thickened and enlarged, and the tendons are less involved. This appearance is sometimes also referred to as the Coca-Cola bottle sign, and I will show you a Coca-Cola bottle in a minute so that you can see where this sign comes from. And another thing that is apparent, so we have thickening of extraocular muscle bellies and less or sparing of the extraocular muscle tendons. And another thing that is apparent on the coronal images is that we see the optic nerve running towards the orbital apex, and we see that it is completely surrounded by these swollen extraocular muscles, especially on the left side, where we can hardly see any orbital fat surrounding the optic nerve. And this phenomenon, or this appearance, is called apical crowding, crowding of the extraocular muscles at the level of the orbital apex, causing compression of the optic nerve. And apical crowding can lead to compressive neuropathy of the optic nerve and visual loss. So it's an important thing to evaluate on the CT scans of patients with thyroid eye disease due to the risk of compressive optic neuropathy. This is another patient with thyroid eye disease, and we see, once again, mainly enlargement of the extraocular muscle bellies, but relative sparing of the tendons, giving the muscles the appearance of a Coca-Cola bottle and hence the Coca-Cola bottle sign. Let's move on and return to apical crowding. Here is another patient, well, it's the same as the previous one, with less orbital fat surrounding the optic nerve at the level of the orbital apex. So this is apical crowding. If the fat in the orbital apex has disappeared, there's a great chance of optic nerve compression. But, and this is something I also frequently ask myself in daily radiological practice, you always see less orbital fat in a patient with thyroid eye disease. When do you need to start calling it apical crowding? When do you really have to point out that there's a risk for compressive optic neuropathy? Because in some patients you see some fat and another patient none at all. When should you call apical crowding? Luckily, there is also a quantitative way to give an estimate on the degree of apical crowding, and that is the Barrett index or the Barré index. I do not know how to pronounce it exactly. It doesn't really matter. How do you do it? Well, you look in the coronal image at the extraocular muscles and the orbit, and you do that somewhere at the level halfway between the posterior aspect of the globe and the orbital apex. And at that level, you measure the width of the muscle bellies of the medial and the lateral rectus muscle, and you make the sum of that width. So, and you divide that by the width of the orbit at the level of the optic nerve. So you do A plus B and divide it by C. So you take the width of the medial and the lateral rectus muscles and you divide it by the width of the orbit at the level of the optic nerve. So a line running through the optic nerve. And then you multiply that with 100, then you get a percentage. And that is basically the Barrett index. And studies have shown that the Barrett index of 60% and higher is very sensitive and specific for optic neuropathy, while a Barrett index lower than 50% practically rules out thyroid eye disease related optic neuropathy. So this is a more quantitative way to estimate the risk for optic neuropathy and give a more quantitative estimate of the degree of apical crowding. And you can also do that in the vertical plane. What do I mean? This is the horizontal Barré index, but you can also calculate the Barré index by measuring the width of the muscle bellies of the superior and the inferior rectus muscles and divided by the width of the orbit and the vertical plane. So you can measure a horizontal Barré index and a vertical Barré index. Then you get maybe two different numbers. The highest number is the one you have to work with. That gives you an idea of the severity of apical crowding. Here's once more how to measure the Barrett index, because I believe that the previous image might have been a bit unclear. So you take the width of the medial rectus and the width of the lateral rectus muscle. You make the sum of the width of both muscles and you divide it by the orbital width at the level of the optic nerve and multiply that with 100. This is the horizontal Barré index. You can do the same in the vertical plane by using the superior and the inferior rectus muscles. Here is another patient with thyroid eye disease, and we see that there is proptosis, especially of the right eye, and we see enlargement of the right medial rectus muscle, but not so much of the left. Well, thyroid eye disease is bilateral 90% of cases and symmetrical in 70%. That means it doesn't always have to be that way. So I always teach my residents there are always exceptions and you have to keep that in mind. So just because this isn't symmetrical, just because this is unilateral, doesn't mean it can't be thyroid eye disease. Furthermore, if you look at coronal image, you see that two muscles are involved on the right side, the medial and the inferior rectus muscle. Well, I first showed you the inferior, then the medial. And that's also no coincidence, because in thyroid eye disease, it has been shown that the disease typically tends to start at the level of the inferior rectus muscle, followed by the medial rectus muscle, and then it has the following appearance of frequency. Mostly involved is the inferior rectus muscle, followed by the medial rectus muscle, and then the superior rectus muscle, the lateral rectus muscle, and the oblique muscles. And if you look at the first letter of each of those muscles, you get I'm slow. And I'm slow is a mnemonic to memorize or help you memorize the order in which extraocular muscles tend to enlarge or the frequency in which they are enlarged in thyroid eye disease. This is what thyroid eye disease, an acute thyroid eye disease, looks like on MRI images. These are fat-suppressed T2-weighted images, and we see, if you enlarge them, that the muscles are bilaterally enlarged. I'm slow. We especially see enlargement of the inferior, medial, and superior rectus muscle, but not so much of the lateral one. And we see muscle edema, hyperintense signal. And on T1-weighted images with gadolinium, we also see, well, the muscles are enhancing, but normal muscles also enhance. But we also see infiltration and edema of the intraorbital fat. And as said, thyroid eye disease not only involves the extraocular muscles, but can also involve the intraorbital occipital fat. This is a patient with chronic thyroid eye disease, and in chronic thyroid eye disease, what you see is that you get fatty infiltration of the extraocular muscles. They tend to become less swollen, might even become atrophic, and we see streaks of fat located in the muscle bellies, and fat is hyperintense on T1 weighted images. So we see these fatty streaks indicating chronic thyroid eye disease. So let's summarize. Thyroid eye disease is mainly characterized by enlargement of the extraocular muscles, mostly bilateral and symmetrical, but that doesn't mean it has to be. It mostly involves the muscle bellies, and the tendons tend to be spared, and the mnemonic "I'm slow" can help you memorize the order of frequency in which the various extraocular muscles are involved. In the acute phase, the muscle bellies will show edema on T2 weighted images, and in the chronic phase, fatty infiltration on T1 weighted images. And something you always have to evaluate is the presence of apical crowding, and you can use the Barrett index to give a more quantitative estimate of the risk for the optic nerve. And let's look at something that looks a bit similar but is not thyroid eye disease. This is a patient with a proptosis of the left eye. So it's a grade 1 proptosis. So the posterior sclera is still located underneath the interzygomatic line. And we see that there is enhancement and thickening of these two muscle bellies, namely the medial and the lateral rectus muscle, as you can see here. This is not what we expect in thyroid eye disease, even if it would be a unilateral asymmetrical thyroid eye disease, then you would expect it to be the inferior and the medial rectus muscle. Furthermore, this patient had a relatively acute development of the proptosis, while in thyroid eye disease, proptosis develops slowly and chronically and is painless. This patient had pain. This was a painful proptosis with painful diplopia. On MRI images, we see enlargement and enhancement of the of the lateral and the medial rectus muscles, and this was a case of idiopathic orbital inflammation, an entity also known as orbital pseudotumor, although this terminology, often still used, is gradually being abandoned. As said, it is idiopathic inflammation. It can be seen in a variety of autoimmune disorders, or is related with various autoimmune disorders like rheumatoid arthritis, Sjögren, what have you not. But if no cause is found, it is called idiopathic inflammation. And despite the fact that I'm showing you enlargement of the extraocular muscles, it's also important to keep in mind that this disease can involve all orbital structures, not just the extraocular muscles, but the extraocular muscle involvement is the most frequent form of idiopathic orbital inflammation, and if extraorbital muscles are involved, that are mainly the lateral and medial rectus muscles. This disease is mostly unilateral, contrary to thyroid eye disease, and has acute symptomatology and can be painful. Steroid treatment, however, generally leads to rapid improvement of both symptoms. This is another patient with idiopathic orbital inflammation, and we see on these unenhanced T1 weighted images enlargement of the inferior and the lateral rectus muscles on the left side. We see that they are enhancing, and more strongly enhancing than the contralateral normal muscles. We see that on both coronal and axial T1 weighted images with gadolinium, and this is very conspicuous on T2 weighted images. We would expect edema, right? Because we associate edema with acute pathology. But in this case, the muscle bellies are very, very hypointense on T2 weighted images. They are so hypointense because this is a disease associated with the formation of fibrosis, and fibrosis is hypointense or black on T2. What kind of disease causes this? Well, there's one thing that should jump to your mind immediately, and that is IgG4 related orbital disease. IgG4 related disease is a disease process that can be multisystemic. It can involve basically any part of the body, but frequently involves the orbital compartment. And very characteristic for this autoimmune disorder is that it leads to fibrosis in the involved structure, and in the case of the extraocular muscles, these will appear dark or be hypo-intense. Idiopathic orbital inflammation, as said already several times, can involve all aspects of the orbits, not just the extraocular muscles. It can be found in the lacrimal gland, causing a lacrimal gland pseudotumor. It can be found in the orbital fat, both in the anterior orbital fat, and then we call it anterior pseudotumor, as well as in the orbital fat at the level of the orbital apex. It can be found in the extraocular muscles, causing myositis, and this is the most frequent manifestation, but can also involve the optic nerve sheath, causing an optic perineuritis. So all in all, several manifestations are possible, and these can be seen in the same, and several of these can be seen in the same patient, causing diffuse idiopathic orbital inflammation. For instance, in this patient, we clearly have involvement of one of the extraocular muscles, the medial rectus muscle, but we also see involvement of the optic nerve sheath with intense enhancement surrounding the optic nerve sheath, as well as infiltration and enhancement of the orbital fat. So this is definitely diffuse idiopathic orbital inflammation and a diffuse orbital pseudotumor. Here are some images of various manifestations of idiopathic orbital inflammation. This is a patient with orbital cellulitis or infiltration of the retrobulbar orbital fat, and also enhancement surrounding the optic nerve sheath. This is a patient with involvement of the lacrimal gland, as well as the muscle bellies of the superior rectus and the levator palpebrae muscle. And this is the same patient. We see that there is thickening and enhancement of the superior rectus muscle, and on top of that, the levator palpebrae muscle. Here we have a patient with mainly involvement bilaterally of the optic nerve sheath. So this is the perineuritic type of idiopathic orbital inflammation. I believe it is probably best seen here on these sagittal T1 weighted images. So this is another patient with something different. We see in this patient, let's magnify these images a bit, we see a proptosis, but it looks bilaterally, so maybe the patient doesn't really have a proptosis, just has these kinds of eyes, because the pathology is unilateral, located on the right side, and we see thickening of the muscle belly of the right medial rectus muscle. This is enhancing on T1 weighted images with gadolinium, and on diffusion weighted images, we see, and it's a bit difficult, of course, because the other structures are difficult to see, but this here is the muscle belly, has a high signal on diffusion weighted images and a low signal on the ADC map. Why is that? Because this is a lymphoma, and a lymphoma is a hypercellular tumor, and hypercellular tumors are often associated with diffusion restriction because they have very narrow intercellular spaces due to the presence of a lot of very small cells, causing limited room for water molecules to diffuse between the cells. Orbital lymphoma is the most common primary orbital tumor in older patients. Once again, it can basically involve any part of the orbit, but is often found in the extraocular muscles. It can be seen as a primary orbital lymphoma, but can also be part of a systemic lymphoma. It can involve any part of the orbit as said, and on MRI is characterized by the presence of diffusion restriction. It will also have a lower signal on T2 weighted images, but generally not so low as we see in IgG4 related orbital disease. So let's summarize our pathology of the conal space and the extraocular muscles. We have seen thyroid eye disease, generally a chronic and painlessly developing disease in which extraocular muscles are, in the majority of cases, bilaterally swollen, and this is often symmetrical. And you can use I'm slow to see if the order of the involved muscles is corresponding with what we expect in thyroid eye disease. In orbital pseudotumor or idiopathic orbital inflammation, the disease tends to be acute and painful, is unilateral in the majority of cases, and mostly involved orbilateral and medial rectus muscles. And orbital lymphoma, then again, is generally a painless disorder, mostly unilateral, and the most distinguishing characteristic on MRI for orbital lymphoma would be the presence of diffusion restriction. This concludes this part of orbital imaging, concentrating on the conal space and the extraocular muscles. The next video will deal with pathology located inside the conal space, the intraconal space. Stay tuned. Hello and welcome to another video on imaging of anatomy and pathology of the eye, orbits, and visual tracts. And in this video, we're going to talk about the intraconal space. So the space in the orbits bordered by the extraocular muscles. And the most important structure in the intraconal space is the optic nerve. So a lot of this presentation will focus on optic nerve pathology. Here is the optic nerve on both sides. We see this linear structure located centrally in the retroorbital fat or the retrobulbar fat running from the eyeball to the suprasellar region over here, where it forms the optic chiasm, not visible on this image. And the optic nerve, if you look on a coronal image, we see that the optic nerve is located here is black. This is the optic nerve itself, and it is surrounded by a small T2 hyperintense CSF space. So it is surrounded by a subarachnoid space, and the T2 hypointense ring surrounding the subarachnoid space consists of arachnoid and dura mater. So the optic nerve is surrounded by meninges, basically like we see in the brain, and that makes sense because the optic nerve can be considered an extension of the brain. The optic nerve is a diencephalic structure. The diencephalon is the embryological part of the brain out of which, for instance, the thalamus arises. So embryologically, the optic nerve is part of the brain, and the optic nerve is also surrounded by brain meninges and by a subarachnoid space. And this will be important also when talking about pathology. This is the optic nerve, and the optic nerve has several components. This is a bit arbitrary, but based on the exact anatomy, we can talk about the extra-ocular part of the optic nerve, and this basically corresponds to the optic disc. It's the very small part of the optic nerve where the optic nerve protrudes into the eye, so at the level of the optic disc or the optic papille. Then we have the intraorbital segment, so the segment running in the intraconal space in the orbit, which is the longest segment of the optic nerve. We have the canalicular segment of the optic nerve, the part of the optic nerve that runs in the optic canal, the bony optic canal. And then we have a rather short part of the optic nerve, the prechiasmatic segment, which is located between the optic canal and the optic chiasm. So these are the various components or the various segments of the optic nerve. And once again, here we have the optic nerve surrounded by pia mater. We have the subarachnoid space surrounding, or the nerve sheet surrounding the optic nerve. And there is the sheet consisting of arachnoid and dura. This is a coronal CT image, and there is no difficulty in detecting the optic nerve. And we also see two vascular structures over here because the intracoronal compartment consists of more than just the optic nerve. It also contains fat. It contains certain blood vessels and also certain cranial nerves. And the cranial nerves are more difficult to see. The most important ones would be the superior and the inferior branch of the oculomotor nerve. And of the vascular structures, we can on most images clearly see the ophthalmic artery located here, supromedially of the optic nerve. And the ophthalmic artery remains in the vicinity of the optic nerve because it enters the orbit through the optic canal along with the optic nerve. And over here we have the superior ophthalmic vein, and the superior ophthalmic vein is located generally superolaterally in the intraconal compartment and enters the orbit through the superior orbital fissure. Now let's talk about intraconal space pathology. And we can make a very broad distinction between intraconal pathology arising from the optic nerve, so optic nerve lesions, and then we have all the rest, the non-optic nerve lesions. And when it comes to optic nerve lesions, I made a distinction for this presentation between optic nerve tumors and inflammation of the optic nerve, so-called optic neuritis. When it comes to tumors, I believe that there are two very important ones you should definitely know. This is a first example. This was a patient with visual disturbances, monocular visual disturbances. And if we look at this CT image, we see some calcifications located along the optic nerve, and the fatty tissue surrounding the optic nerve seems to be infiltrated, or it's all a bit blurry and hazy over here. So what is this? This is the coronal image, and over here we have the optic nerve, and then we have this sheet of tissue which seems to surround the optic nerve and contains a lot of small spickly calcifications. Now the calcifications are a giveaway in this patient. This was an optic nerve meningioma. And as said, the optic nerve is surrounded by meninges, so it is not that extraordinary to have, or not impossible to have, an optic nerve meningioma, although this is an infrequent location for meningiomas. And these meningiomas arising out of the meninges surrounding the optic nerve tend to self-evidently encircle the optic nerve, as you can see here. They often lead to optic neuropathy, and at least, well, about 90 to 95% of patients with optic nerve meningiomas will have some degree of visual loss. And of course, if they wouldn't have, they wouldn't have received an MRI, which kind of makes sense. So it's possible that maybe there are patients with very small optic nerve meningiomas that never get detected because they never develop symptoms and never receive an MRI. But this is all just speculation. So the majority of patients in whom optic nerve meningiomas are discovered have visual deficits. And there's a very characteristic imaging finding, that's the so-called tram track sign, which basically describes the pattern of enhancement of a perioptic meningioma surrounding the optic nerve. So it can be compared to tram tracts because you have this bilateral enhancement on both sides of the optic nerve. So what can we say about optic nerve sheath meningiomas? It is a tumor of adults, typically of adults. That doesn't mean it can't occur in children, but it's definitely less frequent, and most adults are already slightly older, so at least in their 40s or so. It arises from the arachnoid capsules and the meninges surrounding the optic nerve, so same as for meningiomas in the brain, and often associated with visual loss due to optic nerve compression. Concerning imaging, calcifications are often present on CT images. So if you see calcifications surrounding the optic nerve on a CT, that is also very suspicious for the presence of an optic nerve meningioma. And on MRI, you can often see the typical tram track sign of optic nerve sheath enhancement along the optic nerve. This is a patient who has a very large tumor in the olfactory groove. This was a very large olfactory groove meningioma, but we also see calcifications partially encircling the left optic nerve, and this was an optic nerve meningioma. This patient had basically had two meningiomas. These are the axial images of this patient, and we see these calcifications. It looks as if the optic nerve is replaced by calcifications. That's not the case. That's just because the dura completely encircles the optic nerve, and this is probably some kind of partial volume effect. And we can see absence of the normal subarachnoid spaces surrounding the optic nerve on this image over here, on this T2 weighted MR image. So another nice, well, not for the patient, but from a radiological point of view, optic nerve meningioma. This brings us to another tumor of the optic nerve you should definitely know, and this is typically a tumor of children. So optic nerve meningiomas will mostly be seen in adults. This tumor will mostly be seen in children. And this tumor does not arise from the meninges surrounding the optic nerve. No, this tumor arises from the optic nerve itself. If we look at this MRI, we see that the right optic nerve is clearly a lot bigger than the left optic nerve because it is diffusely enlarged due to tumor infiltration. These are T1-weighted images with gadolinium, and we see that there's a diffuse fusiform thickening of the right optic nerve, but without contrast enhancement. This is an optic nerve glioma, and contrast enhancement can be present, but in this case it wasn't. So don't think it's typical for them not to enhance. Sometimes they enhance, sometimes they don't. This, for instance, is an example of an enhancing optic nerve glioma. Now, as said, these tumors are mostly seen in children, typically in the first decade of life, and pathologically correspond to pilocytic astrocytomas, which are very benign WHO grade 1 tumors. Optic nerve gliomas are seen in about 10 to 50% of neurofibromatosis type 1 patients. And if you see them bilaterally, that's almost pathognomonic. And if we reverse it, if you see an optic glioma, well, 50% of optic gliomas are found in patients with neurofibromatosis type 1. So only 50% of optic glioma patients do not have neurofibromatosis type 1. And as said, bilaterally, that's basically pathognomonic for NF1 if you see them on both sides. And this is just another illustration. We see diffuse thickening of the optic nerve. Here's the optic nerve sheet surrounding it, so that's still a bit visible on this side. And we see that this sausage-shaped lesion is diffusely enhancing in this patient. This brings us to the topic of the non-tumorous lesions of the optic nerve, and I'm just going to show you the most frequent and important one. This is a 39-year-old female patient who had genetic cavernomatosis and received a follow-up examination with clinical information, visual disturbances, but not further specified, which is really bothersome for radiologists. The better the clinical information we have, the better our examination will be tailored. Nevertheless, nobody suspected, let's just say that this was a patient with cavernomatosis and even visual disturbances. The idea was, well, might have something to do with the cavernomas, maybe one bled and the occipital lobe or so, but that wasn't the case. Patient had cerebral cavernous malformations, but they were all quiet, no signs of a recent hemorrhage in any of them, and here are just two of them. But what did we see as well in this patient? On this coronal fat-suppressed T2-weighted image, we see that the left optic nerve has an increased signal. A high signal on T2 and on T2 often corresponds to edema. And if we look at the T1-weighted images with gadolinium, it's a bit faint, but we see enhancement of the optic nerve, mainly at the level of the canalicular segment. Now, if you see enhancement and edema of an optic nerve, your diagnosis is well, should be optic neuritis, and that is the most common cause of an acute optic neuropathy in patients younger than 50. Optic neuritis is just a description. It's an inflammation of the optic nerve, whatever the cause. As said, it's not infrequent, most common cause of optic neuropathy in younger patients, and mostly non-infectious. It can be infectious, so it's always inflammatory, but in most cases it is some kind of immune-mediated demyelination. And that can be idiopathic, can stand on its own, but it can also be associated with certain demyelinating diseases like multiple sclerosis, neuromyelitis optica spectrum disorder, or MOGAD, MOC antibody-related disease. It is the typical correlation or association is with multiple sclerosis, and an optic neuritis is the initial symptom in 20% of patients with multiple sclerosis. So if you see an optic neuritis on imaging, especially in a younger patient, especially in a young female patient, you should actually not focus too much on the optic nerve, but you should look at the brain to see if there are signs of a demyelinating disorder. And in this patient, that was the case, but I'll get to that later. Let's first summarize our typical imaging findings in an optic neuritis. In most cases, it's the retrobulbar segment or the intraorbital segment that is involved, and it looks swollen and hyperintense on T2-weighted images. Gadolinium contrast enhancement is present if imaging is performed in the acute phase within 20 days of the occurrence of symptoms, and in the chronic phase, patients can have persisting T2 hyperintensity, but the nerve will look atrophic and will no longer enhance. And here is another example. This is a coronal T1 weighted image with fat saturation, and we see enhancement of the left optic nerve in this patient. In this patient, we also looked at the brain. Well, we did that to look for the cavernomas, and here we have a cavernoma. Let's ignore it for now. We also see a periventricular lesion on this FLAIR image located against the trigone of the left lateral ventricle. It has a bit of a it has an orientation of a Dawson finger and an open ring enhancement on T1 weighted images with gadolinium. So this is a periventricular white matter lesion with open ring enhancement. This is very suggestive for multiple sclerosis. The patient did not have other lesions, so she did not fulfill the criteria yet for dissemination in time and space, but she did so on a follow-up examination. So the final diagnosis was multiple sclerosis. Let's now talk about the other intraconal abnormalities we can see that do not involve the optic nerve. There are a lot of them, so I picked some out. We're going to talk about vascular malformations in the intraconal space. We're going to talk once again about idiopathic orbital inflammation because it can involve all orbital compartments as said in the previous presentation. And we're going to talk about some orbital tumors. Now, this is a very frequent finding, but often incidentally, it's often overlooked. It's you have to look at the eye on every MRI of the brain, and it's sometimes a bit of a forgotten area, especially when patients come for something completely unrelated. But if you look systematically at the eyes on each and every brain scan, you will pick them up every now and then. We see a very small lesion, hyperintense on FLAIR images, slightly hyperintense on T2 weighted images. And on fat suppressed images, it's also T2 hyperintense. This is T1, it's black on T1, and it shows central, somewhat inhomogeneous contrast enhancement. Now, this is a typical cavernous hemangioma, despite the fact that we can no longer use that term. The correct term would be orbital cavernous venous malformation or even orbital venous malformation. I still use the term orbital hemangioma. Why? Because most people are familiar with that term, and because this new terminology is relatively recent, it can create some confusion in my experience. If you suddenly talk about a malformation, everyone automatically assumes it's like an arteriovenous malformation or something like that, and it's easier to just keep calling it cavernous hemangioma. I'm not saying you should do that, it's just what I personally do. Anyways, orbital venous malformations, aka cavernous hemangiomas, are frequent incidental findings. Why should you not call them hemangiomas? Well, because they are not tumors. They are basically venous malformations surrounded by a fibrous pseudocapsule, and they are very often an incidental, asymptomatic, benign finding in the orbit of adult patients, and it is typically located laterally in the intraconal space. On imaging, well, it's basically a structure consisting of blood vessels with slow flowing blood. So you can often see on T2 weighted images a chemical shift artifact because you have this, this is mostly watery. It consists of blood. Blood as a fluid, a watery fluid, and this is fat, intraorbital fat. So we get a chemical shift artifact because it's a border zone between a fatty lesion and between fat, I mean, and a watery lesion. So that is something you often see, and also the inhomogeneous contrast enhancement. What is also very typical for cavernous hemangiomas is that they, even if they are quite big, such as in this patient, they nevertheless cause no real mass effect because they are very soft lesions. And instead of pushing other orbital structures away, this lesion will basically adopt to the anatomy of the surrounding structures. So it will not really push them away, it will just crawl between them without causing a proptosis, without causing other pathology. So it's a soft lesion, and this is also very typical for a cavernous hemangioma. This, on the other hand, was a symptomatic veno-lymphatic malformation. What's a veno-lymphatic malformation? Well, let's just say that these malformations belong to a certain spectrum. And in the veno-lymphatic malformation, we have structures consisting both of venous vessels, enlarged venous vessels, but also lymphatic vessels. This is a T2-weighted image with fat saturation. This patient presented with an acute proptosis, and we see a lesion with a sedimentation level on T2 and a hypointense and hyperintense component. This is very suggestive for blood in this lesion. And if you look on the T1-weighted images, it is hyperintense. We also see the sedimentation level over here. So this is a hemorrhagic lesion. This is a T1-weighted image in the sagittal plane, and this is the contrast-enhanced T1-weighted image. So this was spontaneously T1 hyperintense. These are, as said, vascular and lymphatic structures, and veno-lymphatic malformations are a combination of venous and lymphatic vessels. It is sometimes called a lymphangioma, but just like you shouldn't call a hemangioma because it's not a tumor, the same applies to these malformations. Do not call them lymphangiomas, call them veno-lymphatic malformations. They are congenital lesions. They are, despite the fact that they are congenital lesions, rarely discovered at birth because they're very small at that time and are mostly discovered later in life. And mostly when they become symptomatic. And why do they become symptomatic? Well, it's often because of a bleeding of the lesion into itself, causing an acute painful proptosis and hemorrhage. And they can also become symptomatic following trauma or an upper respiratory tract infection, probably due to repeated Valsalva maneuvers when you are coughing. On imaging, well, basically they follow the signal of they are T2 hyperintense because these channels are filled with lymph, a watery substance, or venous blood, which is also watery. And the venous components will enhance, but the lymphatic components will not enhance. They do not only occur in the conal compartments, but can basically occur in all compartments. And this is a final vascular abnormality. If you look at this image, this was a patient who presented because of proptosis when bending over. This is very peculiar, but also very typical for one specific kind of vascular abnormality of the eye. What do we see? Let's magnify this a bit. On this fat-suppressed T2-weighted image, we see these structures that are T2 hyperintense in the extraconal compartment above the eyeball. Yes, these are located extraconally. Why am I discussing them in a presentation on intraconal lesions? Because, well, they can also occur intraconally, and it kind of made sense to discuss this here when talking about vascular abnormalities of the eye. So that's why I'm discussing it over here. Now, let's continue analyzing our images. So we have these T2 hyperintense lesions. We can't really say they cause a space-occupying effect. They enhance on T1-weighted images with gadolinium. Are they spontaneously T1 hyperintense? Do they contain blood? Well, let's look at the T1-weighted images. No, they don't. And this is following gadolinium, but they do enhance. What could this be? We already suspect them to be of a vascular nature, and then we did something special. Because the patient developed the proptosis when bending over, we performed an MRI with the patient supine, but we also did an MRI with the patient prone. And prone, we saw a significant volume increase of the lesion. And that is something that you will see in one specific condition, and that is a venous orbital varix. What is an orbital varix? Well, basically an enlargement of the valvus, of one or more of the valvus orbital veins. This can be a congenital anomaly, then it's called primary, but can also be secondary. For instance, in a patient with an arteriovenous malformation causing secondary enlargement of orbital veins. We're assuming that in this case, we're dealing with a primary lesion because everything else seemed okay. There is communication with the systemic venous system, and these lesions tend to become bigger in situations in which venous pressure is increased. For instance, when performing a Valsalva maneuver, when sitting on the toilet, for instance, or when coughing. And that's when the patients develop a proptosis, like this patient did when she bent over. They can also present acutely with pain if the patients develop an acute thrombosis or a hemorrhage inside the varix. On imaging, they can be very subtle because they are not enlarged in a supine position. So sometimes you have to do imaging with the patient in a prone position or asking the patient to perform a Valsalva maneuver. Because the patient cannot hold in the breath for 30 minutes or so, that is something you better do on CT than on MRI. Let's talk about a final entity, namely intraconal orbital tumors not involving the optic nerve. Basically, there are two, but I'm only going to show you one. These are the two weighted fat-saturated images, and what do we see? We see a bilateral proptosis, but more of the right than of the left eye, in a patient who also had bilateral lens implants, but that's not important now. On this T2 weighted fat-saturated image in the coronal plane, we see diffuse infiltration of the intraorbital fat surrounding the optic nerves, and this is very heterogeneously enhancing on these fat-saturated T1 weighted images with gadolinium. Look at these coronal images. The intraorbital fat, but not just intraconally, but also in the extraconal space and surrounding the extraocular muscles, is diffusely infiltrated with contrast-enhancing tissue. What was this? This was an extraocular orbital metastases. This is not so frequent, it's uncommon, and considerably less common than the uveal or the choroid metastases we talked about earlier in this series. It is seen in less than 1% of patients with metastatic disease, and it is characterized by tumor infiltration of the intraorbital fat and or the extraocular muscles. It is frequently seen in, or one of the cancer types in which it is more frequently seen as breast cancer. And in breast cancer, it can, ironically enough, be associated with an enophthalmos because this tumor infiltration has a kind of desmoplastic effect, pulling the eyeball into the eye socket. And it can be uni or bilateral. An intraorbital lymphoma can also give a similar appearance, although intraorbital lymphomas, which can also be seen in all orbital compartments, tend to be more mass forming. This concludes my presentation on the intraconal space. Stay tuned for the extraconal space in the next presentation. Hello and welcome to this short presentation on pathology of the extraconal space. So in the previous presentation we talked about pathologies in the intraconal space. The extraconal space is, as the name implies, the space located in the orbit exteriorly of the extraocular muscles. And we know this drawing, we've seen it in the presentation on extraocular muscle pathology. Here we see the extraocular muscles, and of course the extraconal space is located exteriorly from the conal space or the extraocular muscles. And what does it contain? Well, mostly fatty tissue. And in this fatty tissue, we find the lacrimal gland located superolaterally in the extraconal space, as well as blood vessels, arteries and veins, and several cranial nerve branches. If you want to be more specific, we find the trochlear nerve in the extraconal space and branches of the ophthalmic and maxillary division of the trigeminal nerve. And I've just drawn some of these nerves, arteries, and veins for you. Superlaterally, we find the lacrimal artery, vein, and nerve for the lacrimal gland, self-evidently. We find the zygomatic nerve, a branch of the maxillary trigeminal branch, supero-inferiorly in the extraconal space. Infero-medially, we find the inferior ophthalmic vein, and then we have the supratrochlear artery and nerve and the superior ophthalmic vein and finally supraorbital artery and nerve. This is just by way of illustration because most of these are not clearly visible on imaging, even on MRI images. So this is just an illustration, but these are the contents of the extraconal space, the lacrimal gland, fatty tissue, and blood vessels and nerves. So if we encounter pathology, it will involve one of these structures. This is an illustration of the extraconal space, well, basically of the orbit in the sagittal plane. I made it myself. I'm very proud of it. Took me a while. Here we have the globe and the optic nerve. Then we have the extraocular muscles, which divide the intraorbital space in an intraconal compartment and an extraconal compartment. I'm going to introduce a new barrier now, which is the orbital septum. The orbital septum is a small, well, let's call it a membrane or a band of a fibrous tissue, which basically forms a barrier between the orbit and the extraorbital subcutaneous fat. And we have the orbital septum surrounding the orbit, and it attaches on both the superior, on the orbital roof and the orbital floor inferiorly and orbital roof superiorly, and it also attaches on the tarsal plates of the eyelids. And the tarsal plates are bands of tissue that basically provide some support or some stiffness for the eyelids. So the orbital septum is quite important, despite the fact it's a very small structure that is difficult to visualize on CT and MRI images, but it's important to have a rough idea of where it is located because in this presentation I'll talk about intraorbital infections and whether an infection is located in front of the orbital septum or behind it will have tremendous implications for patient management. So we know this illustration. I made a similar illustration in one of the first presentations on this topic. And we see here the orbital septum, basically forming the barrier between the orbital space and, well, let's call it the exterior tissue. And this is just an anatomical illustration with the orbital septum shown in red running from the orbital roof and the orbital floor respectively and inserting on the tarsal plates of the eyelids. And as said, it's very difficult to see. We see here this arrow, this very, very small linear structure is the orbital septum, the superior part. As said, very difficult to see, and here we see it on an axial figure. So it's often difficult to see, especially when a patient has a lot of inflammation going on in the subcutaneous soft tissues. So it's more important to have a rough approximate idea of where it is located. And where is that, or what's an important landmark? That would be the canal or the lacrimal canal, because the orbital septum inserts on the medial side posteriorly of the lacrimal canal. So look up the lacrimal canal and then you can draw a line along the margin of the orbit and you have a rough idea of the course of the orbital septum. As said, this will be very important when dealing with orbital infection. So when it comes to extraconal space pathology, it's actually quite diverse, the spectrum of lesions you can encounter in that space, but a lot of these are also very infrequent. So I was a bit selective and I'm going to show you especially orbital infection and inflammation. I'm going to talk briefly about lacrimal gland lesions, but I'm not showing you many cases because I don't have that many. And vascular lesions are also things you can encounter in the extraconal space, but we already covered those in the intraconal space because the same kind of vascular lesions like a lymphovenous malformation or an orbital varix, they can occur in both the intra and extraconal spaces. So I'm not going to cover those again. Let's talk about orbital infection and inflammation. This is a patient with a swelling of the the right eyelids. Clinically, the patient was suspected of having an orbital cellulitis, but it's very important to make a distinction between a cellulitis that is located anteriorly of the orbital septum and an cellulitis that is located behind the orbital septum. And that's basically the only reason why imaging is done in these patients, to determine is the infection pre-septal or post-septal. If the infection is purely pre-septal, oral antibiotics are a sufficient treatment and the patient can be sent home again. If it is a post-septal infection, the patient will have to be administered, will have to receive intravenous antibiotics, and depending on what is going on exactly, maybe even surgical decompression. So a totally different approach or totally different treatment. This is a patient with clinically an orbital cellulitis, and then the question is pre-septal or post-septal. So we see swelling of the subcutaneous tissue of the eyelids, on the right side. And if we keep in mind that we have to look up the location of the orbital septum, well, it's roughly located over here. We see no signs of infection or inflammation of the orbital fatty tissue located behind the orbital septum. So this is a pure pre-septal cellulitis. Oral antibiotics are a sufficient treatment in this patient. Here's another example. And you could say, well, it's a bit difficult. You just have to assume that the orbital septum is located over there and then call it a preseptal cellulitis. Yes, that's true. But if you really want a little bit more certainty, look up the lacrimal canal located over here. And if you see no signs of infiltration of the fatty tissue behind the lacrimal canal, you can call it a preseptal cellulitis. And in this patient, we see a lot of fatty tissue graying, a lot of fatty tissue infiltration. So this is quite extensive, but nevertheless does not involve the retrobulbar fat. Also notice that this patient clearly has a sinusitis, and an orbital cellulitis is often secondary to sinusitis. As already said, the ethmoidal plate of the medial orbital wall is very, very thin, contains a lot of canals for very small vessels, and an infection can spread along these canals from the ethmoid cells into the orbital region. So very often this is secondary to sinusitis. Another cause could be an odontogenic infection that has spread to the masticator space and then following certain pathways has reached the orbital compartment. So look for the lacrimal canal to determine if it is a pre or post-septal cellulitis. Here's another example. The patient clearly has a proptosis of the right eye. And if you have a proptosis, you have to assume that there's something in the orbit that has a space occupying effect, pushing the eye outwards. And is that the case? Well, it definitely is. Here we have the lacrimal canal, and we see that there is clear that is something going on behind the orbital septum. So we are dealing with post-septal pathology. What is it exactly? Well, here we have a hypodense collection located in the extraconal compartment, medially of the medial rectus muscle, which is pushed away by this collection, as well as the eyeball, which is pushed away. This is a subperiosteal abscess. It is an abscess located underneath the periosteum of the medial orbital wall. And once again, we see clear signs of sinusitis involving the right ethmoid air cells in this patient. This is the same patient in the coronal plane, so we see that the patient has a very extensive bilateral sinusitis, but more pronounced on the right side, and we clearly see a subperiosteal collection in the extraconal space medially of the medial rectus muscle and medially of the eyeball. This patient will definitely need to be administered, will need to receive intravenous antibiotics, and maybe even a surgical drainage of the sinuses and the subperiosteal abscess. So to summarize, an orbital infection is often a complication of sinusitis, but can also be secondary to an odontogenic infection. It is very important to see if there is pure involvement of the orbital subcutaneous fat anteriorly of the orbital septum, or if there is infiltration of the fatty tissue behind the orbital septum. And based on that, we can make a distinction between several stages of orbital infection. Stage 1 is the preseptal cellulitis, and basically that's the most important thing, make a distinction between preseptal cellulitis and everything else. And what is everything else? Well, stage 2 is an orbital cellulitis, so be careful when using that term. I sometimes said orbital cellulitis to talk about orbital infection in general, but it can be confusing because here what is meant is infiltration of the post-septal fat. There is no abscess there, no collection, but there is infectious infiltration of the fatty tissue, an orbital cellulitis. Stage 3 would be a subperiosteal abscess, of which I've showed you an example in this presentation, and stage 4 is an orbital abscess, so an abscess located not subperiosteally, but really behind the eyeball and the intraconal fatty tissue. And a complication of these infections can be cavernous sinus thrombosis. So if you do contrast-enhanced imaging of the orbits, always look up the cavernous sinus and look for signs of thrombosis in patients with an orbital infection. Here's a patient with very extensive T1 hypointense lesions medially and somewhat inferiorly in the extraconal compartment on both sides. These are intensely but somewhat heterogeneously enhancing, as you can see on this T1 weighted image with gadolinium, and on a T2 weighted image, fat saturated, we see that these lesions are very hypointense. Where have we heard or seen that before? Yes, when talking about idiopathic orbital inflammation. But in this patient, the orbital inflammation is not idiopathic. The lesions are very hypointense, so this is suspicious for IgG4-related orbital pseudotumor, which, as said, can involve any orbital compartment, and in this patient, it involved the extraconal compartment bilaterally. Here's another patient with a non-infectious orbital pseudotumor involving the lacrimal gland on the left side. We see diffuse enlargement of the left lacrimal gland, which is hyperintense on the two weighted images, suggestive of edema, and which is intensely enhancing on the T1 weighted images with gadolinium. So this was an orbital pseudotumor, and the lacrimal gland is the second most commonly involved structure in idiopathic orbital inflammation, or so-called orbital pseudotumor, next to the extraocular muscles. This is a lesion which at the first glance appears to be located in the lacrimal gland, but was actually located in the vicinity and compressing the lacrimal gland. It was not primarily located in the gland, and it is very hyperintense on T2 weighted images. I'm talking about this lesion over here. And on these coronal T2 weighted images, we see the lesion on this side being very hyperintense, but somewhat heterogeneous. And on T1 weighted images, we see that the lesion is also very hyperintense. The gadolinium administration was given to the patient. There was no clear enhancement, but of course difficult in a lesion that is spontaneously T1 hyperintense. Now, what is hyperintense on T1 weighted images? Could be fat, could be blood. How to make the distinction? You could do fat-saturated MRI sequences. This was not done in this patient, but we did a CT, and the CT images will follow later, I believe. These are the T1 weighted images showing you the T1 hyperintense lesion. Oh, and here is the CT, and the lesion is very, very hypodense, and the density was somewhat minus 70 Hounsfield units, so this was fatty tissue. Also notice the hypodense aspect of the lesion on these coronal images. This is a fatty lesion, so the differential diagnosis is already limited, and it has a very typical location for one specific lesion, and that is a dermoid cyst. A dermoid cyst is the most common orbital mass in children. It is a congenital fatty lesion, just like an epidermoid cyst. It's an ectodermal inclusion cyst, so a congenital inclusion cyst aligned with epithelium, filled with keratin debris, but contrary to epidermoid cysts, these also contain hair follicles, sweat glands, and sebaceous glands, and these latter, these secrete fatty some kind of oily, fatty fluid, which give the lesions their very characteristic T1 hyper-intense signal on MRI and their very low density on CT. Despite the fact that they are congenital, they are generally not visible at birth, grow very slowly, and slowly become manifest in the first decade of life. And they have some typical locations. They are generally located in the extraconal space and can typically be found either in the upper outer quadrant, near the frontozygomatic suture, or in the lacrimal fossa region. Now, when it comes to lacrimal gland lesions, I have no extensive cases to show you, but a differential diagnosis is actually not that difficult if you just think about it logically. What can cause an enlargement of the lacrimal gland that will either be an infectious or inflammatory process or a neoplastic disease, right? And when it comes to infectious, well, these can be viral or bacterial. The distinction is generally not easy to make on imaging, but let's just say we call it dacryoadenitis when it involves the lacrimal gland, and a dacryocystitis when it involves the lacrimal sac. When it comes to inflammatory disorders, we have, of course, orbital pseudotumor or idiopathic orbital inflammation. Also, a possible cause of inflammatory lacrimal gland enlargement would be sarcoid and Sjögren, and in those cases it tends to be more often bilateral, while in the orbital pseudotumor it is more often unilateral, but not always. Finally, we have neoplastic disease, and when it comes to neoplasms of the lacrimal gland, it's quite simple. The lacrimal gland is one of the salivary glands, contains epithelial cells, but also lymphoid tissue. So what will we see in lacrimal glands, or what kind of tumors do we encounter? Well, lymphoma constitutes about 50% of lacrimal gland tumors, and then we have the so-called epithelial lacrimal gland tumors. Belonging to those are pleomorphic adenoma, which is a benign tumor, and the most frequent malignant tumor would be adenoid cystic carcinoma. It's not always possible to distinguish these different types of tumors on images, but keep in mind that what applies for lymphomas in the brain or somewhere else, that they are diffusion restrictive, that's also true for a lymphoma in the lacrimal gland. Pleomorphic adenomas are very benign lesions, so will generally not show, for instance, erosion of the surrounding bone of the orbit, while a very malignant adenoid cystic carcinoma can do just that. So these can be some clues to provide a more specific differential diagnosis, or say it's going to be more likely pleomorphic adenoma or lymphoma or adenoid cystic carcinoma. This list is not complete, but I believe as a general radiologist, there's no point in remembering lists of 10 or 20 differential diagnoses. I think it's most important to have an idea of the most common types of pathology, and I believe this slide covers those. So this was a very short presentation, and we're almost through with our series on imaging of the eye, orbit, and visual system. The final presentation will involve extra-orbital anatomy and pathology. Stay tuned. And welcome to this last presentation on imaging of the eye, orbits, and visual tracts. So the previous presentations mainly focused on anatomy and pathology of the orbit. We talked about the globe, we talked about the conal, intraconal, and extraconal space, and so on. In this final presentation, we're going to leave the orbit and talk about the visual pathways beyond the orbits. So we're going to talk about the visual system as it is in the rest of the brain. And I'm going to make a distinction between two functional structures, let's say. I'm going to talk about the optic pathway. So basically the pathways that transmit the information from the retina to the occipital cortex, and I'm going to talk about the oculomotor pathway. So basically the pathways that go from the brainstem to the extraocular muscles and provide the innervation of the extraocular muscles and thus are important for eye movement. This is not going to be a very extensive or detailed presentation because, well, let's be honest, I try to cover the entire visual system in these series of presentations, but this leads to, if you combine all these presentations, a presentation of about 2.5 to 3 hours, which is very, very long. And I got something in the making on cranial nerve anatomy and pathology, so I promise I'm going to go more into detail in this future presentation. Now, let's get started. So, to make things simple, when it comes to the extra-orbital pathology of the visual system, I make a distinction between the optic pathways involving the second cranial nerve, the optic nerve, and there are two regions that are very important. That is the optic chiasm, and the optic chiasm can be directly involved by certain pathological entities, but also indirectly. It can be compressed by neoplasms in the neighboring structures, and very important is the pituitary or the cell region, because a macroadenoma of the pituitary will be a lesion, the most frequent cause of compression of the optic chiasm, because the sella turcica is located underneath the optic chiasm, or if you put it the other way around, the optic chiasm is almost always located above the sella turcica, almost, well, in about 70 to 80% of cases. So we're going to talk a little bit about the cell region and lesions causing compression of the optic chiasm, and then we're going to talk about the optic pathways in the brain parenchyma, and the most important region will be the occipital cortex, which contains the primary visual cortex. Then I'm going to talk a little bit, and I'm going to start with that, about the oculomotor pathways, so the pathways of the third, fourth, and sixth cranial nerve. And there are certain brain regions that are important, the regions through which these cranial nerves pass. They go from the brainstem. From the brainstem, they run into the basal cisterns, and from the basal cisterns into the cavernous sinus. So we're going to talk a bit about the cavernous sinus, the basal cisterns, and the brainstem. Let's start with a short repetition or a short description of the anatomy necessary to understand the oculomotor pathways. I magnified this a little bit, and I even provided some textual information. So what brain regions are important? Well, the nuclei of the oculomotor nerves are located in the brainstem, more specifically in the mesencephalon and the pons, depending on what kind of oculomotor nerve we're talking about. And they leave the brainstem and then run through the basal cisterns. This is the oculomotor nerve, so the nuclei are located dorsomedially in the mesencephalon. Then the nerves run through the mesencephalon, leave the mesencephalon in the interpeduncular cistern, and run through the basal cisterns. The trochlear nerve, so this is a pretty short route to the basal cisterns, but the trochlear nerve, for instance, crosses, so runs to the other side, and has a very long course in the basal cisterns. Anyways, this is not going to be a detailed discussion on anatomy. That will be for a future presentation. Then all nerves, the third, fourth, and the sixth, run through the cavernous sinus, and then they enter the orbit and the superior orbital fissure to innervate. So basically at the level of the orbital apex, and then they innervate their respective extraocular muscle. And this is an example of a patient who has something going on in the cavernous sinus. What that is exactly, well, you can't see it on these images. The only thing we see, and it's quite subtle, I must say, if you look at the T1-weighted images, you see I drew a line there, the interzygomatic line, and there is a slight proptosis of the left eye. And then if we magnify this region a little bit, or look at this region, we see some enhancement. And these look like very linear structures, could be vascular. are these vascular structures? Well, yes, they are. Let's look at this T1 weighted image with gadolinium, and we see that there is enlargement of the superior ophthalmic vein. This can have two causes. Well, first of all, there can be a lesion causing increased intracranial pressure, but that is not the cause or the case here. And two other possible causes here or a thrombosis of the cavernous sinus or a carotico-cavernous fistula. And if we look at the TOF angiography, we see that there is an arterial signal, there is increased signal in the superior ophthalmic vein, and this could be secondary to an arteriovenous shunt. And does the patient have one? Well, yes, the patient did have a carotico-cavernous fistula, so a direct connection between the carotid system and the venous system at the level of the cavernous sinuses. And we see here, this is not the ophthalmic artery, no, this is the superior ophthalmic vein, which opacifies in the arterial phase because there is an arteriovenous shunt. And we can actually see the shunt over here at the level of the cavernous sinus. So a carotico-cavernous fistula is a shunt between the carotid sinus and the cavernous, the carotid system rather, and the cavernous sinus. You have various subtypes. They can be traumatic, but also atraumatic. They can be low flow, they can be high flow, and you can have direct shunts and indirect shunts, but that is something that's more of importance for an interventional radiologist. And when it comes to the clinical symptoms, the majority present with a pulsatile proptosis. So there's a proptosis of the eye, but the eye also pulsates a little bit with each heartbeat. Patient can also have chemosis, so swelling and redness of the eyelids and the conjunctivae, do I pronounce that correctly? They can have cranial nerve palsies and visual loss. This is another patient, and this patient presented with an abducens palsy. And if we look at the sagittal T1 weighted images, at a first glance, we'd say, oh, this could be a pituitary tumor. But what is a bit strange is that we would expect the lesion to cause a bitemporal hemianopia, but, well, doesn't have to be. There is no compression of the optic chiasm. Nevertheless, abducens palsy caused by pituitary adenoma is not that frequent, but it's possible. Let's look at an axial image, and what do we see? We see a left paracellar region that is very hypointense on T2 weighted images. Now, what can be hypointense on T2? This could be acute blood, but it can also be flow void. So this could be a hemorrhage or it could be a vascular lesion. What is it exactly? Well, if we assume it's a vascular lesion, maybe we need to do vascular imaging. And what do we see on the TOF angiography? We see that there is an increased signal over here. And on this classical angiography, we see that this is actually a large aneurysm of the cavernous segment of the internal carotid artery. And because this compresses the cavernous sinus, and especially the abducens nerve, so all oculomotor nerves, so the third, the fourth, and the sixth, they all run through the cavernous sinuses, but the third and the fourth are located in the lateral wall of the cavernous sinus and are a bit more protected over there, but the abducens nerve lies centrally within the cavernous sinus, very near the carotid artery, so it's very susceptible to being involved in a pathological process of the cavernous sinus. So compression here led to an abducens palsy. Another cerebral aneurysm that can give rise to cranial nerve palsies would be a PCOM aneurysm. So there are two aneurysms that can give rise to cranial nerve palsies, the cavernous, an aneurysm of the cavernous internal carotid artery, which generally causes an abducens palsy, but a PCOM aneurysm can give rise to an oculomotor palsy, so a palsy of the third cranial nerve. And why is that? Because the third cranial nerve runs between the posterior cerebral artery and the superior cerebellar artery in close proximity to the PCOM. So PCOM aneurysms can actually compress this cranial nerve. This is a patient with a painful ophthalmoplegia, and on the one-weighted images with gadolinium, if we magnify these a bit, we see a plate-like contrast-enhancing lesion involving the right cavernous sinus. So this is the cavernous segment of the internal carotid artery over here. So you could say, well, the cavernous sinus is composed of dura mater, and within these dural layers we have these channels filled with venous blood rather. Okay, but the meningioma of the cavernous sinus will generally not manifest with a painful ophthalmoplegia. The fact that it is painful is more suggestive of a rather acute or quickly developing lesion, possibly an inflammatory lesion, and this was a patient with a so-called Tolosa Hunt syndrome. The Tolosa Hunt syndrome can be compared to the idiopathic orbital inflammation. It is an idiopathic inflammatory disorder that responds well to steroids, but involves the cavernous sinus and/or the orbital apex. And because the cranial nerves run through the cavernous sinuses and enter the orbit at the level of the orbital apex, this entity can be involved or can lead to a painful ophthalmoplegia. So it's an idiopathic disorder and it's an extra-orbital pseudotumor, basically comparable to the idiopathic idiopathic orbital inflammation. So let's now move on to pathology of the optic pathways. And there are two regions that are important. We already discussed extensively pathologies of the globe and the optic nerve, which will give rise to monocular blindness. Now we're going to talk about lesions involving the region of the optic chiasm. And if there is central compression of the optic chiasm, patients will have bitemporal hemianopia. If there is pathology involving the optic tracts, the optic radiation or the visual cortex, patients will have a homonymous hemianopia. This is the optic chiasm, so let's talk shortly about anatomy. Over here we see the prechiasmatic segment of the optic nerve, so the segment that is located beyond the optic canal right in front of the optic chiasm. Over here we have the optic chiasm, and this here is the optic tract, which sends fibers to the thalamus, more specifically to the lateral geniculate body of the thalamus. There they synapse, and then we get second-order neurons, which give axons to the occipital cortex. This is probably the most important entity when talking about the optic chiasm, and this is a tumor of the pituitary, more specifically a macroadenoma. And the arrow points to the optic chiasm, which is located immediately above and is compressed by the tumor. Over here, we see coronal T2 weighted images, and we see the optic chiasm clearly being compressed, and this patient can have clinical symptoms of a bitemporal hemianopia. This is a more subtle finding. This was a patient who might have, I'm not sure, it was not found in the medical records because the patient was difficult to evaluate clinically, but we expect this patient to have a homonymous hemianopia. So this was a patient with infarctions and the right anterior cerebral circulation, and we also see that there is an increased T2 signal in the right optic tract with some increased signal on diffusion weighted images. So this is probably an acute ischemic infarction of the right optic tract. So we suspect or expect this patient to have a left-sided hemianopia. Infarctions of the optic tract are not something you see on a regular basis. The optic tract is supplied by the anterior choroid artery, anterior choroid artery infarctions exist, but they are not that frequently seen in daily radiological practice. So the chances you see this are not null, but also not so big, I'd say. This is a 75-year-old male patient with acute right-sided hemianopia, and on these CT images we see an area of edema involving the left occipital cortex, both on these axial and sagittal images. This is another patient. These are MRI findings. This patient also had a right-sided hemianopia, and we see an area with diffusion restriction and increased flare signal involving the occipital lobe corresponding to a vascular territory. So these were both patients with left-sided infarctions of the posterior cerebral artery territory, leading to infarctions of the occipital cortex, which contains the primary visual cortex. Last case, this is a patient with extensive edema and a non-vascular distribution in the left occipital lobe, and we see that there is an irregular, centrally necrotic mass lesion involving the cortex of the left occipital lobe. This is heterogeneously enhancing on these T1-weighted images in the axial and sagittal plane, and this could be a glioblastoma or metastases. On a nuclear scan, on an FDG PET-CT, the patient had a mass lesion in the left lung, and this was a lung cancer metastasis. Okay, this was the final part of our series of presentations on visual anatomy and pathology. What do I want you to remember from all these presentations? So I don't know if you've seen them all. If you haven't, well, maybe please do. So first of all, it's very important if a patient has visual disturbances or vision loss, it's very important for us as radiologists to know what to scan exactly, because if the patient has monocular blindness, the pathology will involve the orbits or the optic nerve, and you will do a dedicated MRI of the orbits. In a patient with bitemporal hemianopia, you will do an MRI of the pituitary, and in a patient with homonymous quadrant anopia or hemianopia, you will do brain imaging. Now, if you have a patient with an orbital floor fracture and diplopia, definitely check if there is a herniation of the inferior rectus muscle. And a patient with sinusitis or a masticator space infection and a proptosis, look for post-septal involvement of the orbit. So definitely look behind the septum to see if there is an abscess there or infiltration of the fat over there. And a patient with thyroid eye disease and a proptosis, look for apical crowding and use the Barrett index to maybe quantify this a little bit and estimate the degree of severity. If you have a young patient, especially, well, it doesn't really matter if it's a man or a woman, but we expect it's more frequently seen in women, and a young patient with an optic neuritis and a clinical suspicion of optic neuritis, basically brain imaging will be more important than orbital imaging. Because, okay, the clinical suspicion is optic neuritis, you can do an MRI of the optic nerve and then see, hey, yeah, it's an optic neuritis. But then the next question is, what's causing it? Is it an optic neuritis and nothing more, or is it part of multiple sclerosis or another demyelinating disorder? So definitely consider doing brain MRI in patients with an optic neuritis, especially young patients. If you see a retinal detachment, especially in somewhat older patients, carefully inspect the globe to see if there's an underlying extra-ocular tumor. This can be a metastasis in older patients or a melanoma, and will be T1 hyperintense if it's a melanocytic melanoma. And in patients with cranial nerve palsies, the cause is most often located outside of the orbit. So in these patients, also do an MRI of the brain and preferentially add some dedicated sequences for detailed visualization of the cranial nerves. But as said, I am working on a presentation on cranial nerve anatomy and pathology, and I hope to discuss that topic in a bit more detail in the future. So once again, a lot of thanks to my excellent colleague, Dr. Stephanie van den Bosse. I used a former presentation of hers to make this presentation, but her presentation was based on an even older presentation of myself. So basically, I also want to thank myself for making that initial presentation. And no, really, I want to thank Stephanie because she really did a nice work and it was really helpful for me to make this presentation. If you have any questions, comments, or feedback, send me an email or leave a comment at the comment section. Thank you very much for watching. It's a long series. I hope you found it interesting and useful.